Welcome to Pemba On Demand. I'm Norm Chapin, your host. I am very excited to welcome you to our podcast. Pemba On Demand is produced for physicians interested in professional development. We will be discussing a wide range of topics on the podcast. I will be interviewing physician leaders from the U.S. and from other countries who have graduated from the Physician Executive MBA program at the University of Tennessee. These physicians will be sharing stories of professional and personal growth, overcoming challenges in their organizations, and discussing key leadership skills they have learned from the MBA program and ongoing professional development. Our guest today is James Daniel Moore. Dr. Moore is an associate professor at the University of Kentucky Healthcare and is also the co-CEO and chief financial officer for Thoroughbred Emergency Physicians. Dr. Moore graduated from the University of Kentucky Medical School back in 2011 and then completed his emergency medicine residency at the University of Alabama. He also recently completed his MBA at the University of Tennessee Knoxville, so he's a fellow Pemba alum. Welcome to Pemba On Demand, Daniel.
Thank you. Glad to be here.
Well, it's great to have you here. I've been looking forward to this live stream now for several months as we've talked about your project. And as you, the audience, can see from our title, Daniel is going to be discussing kind of a very innovative approach he developed and spearheaded while at the University of Kentucky to tackle a specific infectious disease that's really very prevalent in his region and community, hepatitis C. But before we launch that discussion, I'd really like to talk with Daniel a little bit more about just your medical career. And I wondered if you would mind sharing some of the reasons you chose to enter into kind of an academic emergency medicine practice after you completed your residency.
Well, those of you who know me before I was in academics would know that I never had any intention to do that. When I was a resident, I told them I wanted to get out, practice community emergency medicine, go show up for shifts and go home. And I was probably out 2 to 3 months before I realized that the system was broken, particularly in Kentucky. At the time in residency, I was practicing within a very well-ran healthcare system at UAB and didn't really have to deal with a lot of the problems, for instance, boarding at the time that I got dealt with when I came to Kentucky. And very shortly after being out in practice, I told my wife, I said, we either have to leave the state or I have to try to figure out how to fix all these problems. And we kind of landed on trying to fix the problems. So I actually went to the University of Kentucky to try to fix a lot of the problems. And that was what my goal was upon entering there. And it was really using an academic healthcare system, a nonprofit organization with a lot of resources in order to fix healthcare infrastructure. There have been certain aspects of academics and teaching. I've always loved teaching residents and students, but that wasn't my primary goal. It never has been. I've always viewed academics and education as a means to the end of treating patients and not the other way around.
So it just from my experience, was there any trade-off between or concerns that you had about entering sort of a large organization and trying to make changes in a large organization versus working in a smaller scaled organization? I know that talking with other physician leaders, sometimes the pace of change seems very different between those two types of organizations. How did you find that, and how did you feel about that as you chose to go back into a large academic healthcare setting?
Well, I can answer that retrospectively now, 10 years later, knowing the differences. But when I was fresh out of residency, I was naive to all that. And thankfully, because I probably wouldn't have done it. So I wasn't in a position of making change in residency or shortly after residency. And over time, that took building credibility, building success within projects to even be sitting at the table for making change. So, it is moving the Titanic with any type of major project, but I've been involved with many at this point, and it's frustrating. But if you keep the endpoint in mind, which is patient care and access to care and those types of things, if you're really driven by those things, it's not that hard to be persistent within difficult systems. And honestly, being able to speak the language of those who are in control of change, such as with business, I've never had a real project ever where I've wanted to do something that I've been told no to if you have an adequate reason to do it and plan on how you're going to do that. So, while it takes a long time, it's also, has been reassuring that there are a lot of people that still really care, as long as you can make an argument as to why you want to do something.
So you were really committed to being a change agent early in your career. And how did you go about learning what you needed to learn in order to successfully navigate that?
So it started out going to ACEPS. I'm an ER doctor. So it started out going to ACEPS, Emergency Department Directors Academy, where I remember the very first lecture I ever had from Jody Crane. I thought a lot of the operational change in healthcare systems was opinion. I thought that it was not science-based, not evidence-based, and I quickly learned that was not the case. I think that's when I became fascinated with the math and science and strategy and theory behind it. And, this program was recommended at that ACEP EDDA conference. And this was 2015, I think, when I was there. That's kind of how I got introduced to this type of work. And then I read Jody Crane and Chuck Noon's book before I came to this program, and Jody knows this, and Chuck, who was my mentor, knows this as well. But I just implemented what they did. I mean, I read every piece of literature there was, on emergency department, because we still have objectively the highest boarding I've ever seen in any benchmark analysis at the University of Kentucky, over 400,000 hours of boarding, and people were dying in the waiting room at the time. And I set out to try to figure out how to fix those problems. And so I educated myself as much as I could and implemented everything that had been written, and we had massive success. So, we had 0.2 left out being seen rate for years. We in the midst of 400,000 hours of boarding, cleared out our waiting room so effectively that we turned our waiting room into treatment space, created capacity for several 100,000 extra patients, it made University of Kentucky several $100 million of incremental contribution margin. And that was my introduction to kind of baptism by fire of business. And I realized through working with a lot of really great business people within UK that this was what I had to do in order to accomplish change. I really had to be able to speak the language of the executives. And now looking at it on the back end, I look at other physicians that are trying to make change when they have no idea what they're talking about from a business standpoint. I understand why there was a gap between those things. So I'm a huge fan now of physicians educating themselves on these topics, which I had none of this education in medical school or residency. So it all kind of happened incidentally, but that's the path I took.
Yeah, it's kind of interesting how little process improvement work we get exposed to in medical school and residency. And my exposure came similar to yours after I finished my training, years after I finished my training, but prior to starting my MBA program. And it sounds like you immersed yourself in that change management learning opportunities before you started the MBA. But what was it that made you decide, after starting working with these ACEP medical director programs and really having fairly large success, it sounds like, in your emergency department, changing it, what was it that really tipped the balance for you and made you decided that you needed to go on and get the formal MBA degree?
Well, at the time, I felt like the credentials were important. I mean, so just, for whatever reason, the letters behind your name do matter some in an academic setting. So that was part of it. But I also wanted a program that was actually going to teach me something. For instance, I had access for free to the University of Kentucky's MBA program, and I chose to spend my own money out of my own pocket to come to UT's PIMBA program. And I had no support from the University of Kentucky for this because I had access to a free MBA program. And Jay Grider, who was the chief physician executive at the University of Kentucky, was a PIMBA graduate, and he has been a mentor of mine in this area. And he very strongly suggested, his exact words to me were, "It will be worth every penny to you, Daniel," which is true, looking back. And he's the one who ultimately convinced me to come through this. And of course, I had already been exposed to Chuck and Jody. Chuck also had come to the University of Kentucky to do some training right before COVID. We were actually about to have a huge intervention on hospital flow. And actually, it's kind of sad because we had quite a bit of momentum for the healthcare system at that time, right before COVID hit. But I had been exposed to all of them on several different fronts. And as an ER doctor, I felt like this was a relatively heavy ER centric program. So it was kind of a no-brainer for me to come to this program.
Had you considered other advanced degrees? And again, just looking at the work you've done in hepatitis C, I guess one of the things I wondered whether you had considered a master's in public health because of your interest in epidemiology, or did this interest in tackling these kind of public health emergencies arise after you had decided to pursue the MBA?
I definitely did. But anybody who has worked in hepatitis C work knows that the people who have a bleeding heart for these types of issues have been ineffective making change. And I'm not saying that they're not good people, not intelligent people, but they're not equipped the same way that somebody with business skills is. So, having the clinical knowledge as an ER doctor, I knew that in order to make actual operational change, it meant a lot more than just caring about a public health problem. So yeah, I was interested in those things. I looked at all kinds of different types of programs at the time, and I landed on needing an MBA because I wanted to change systems. This particular program and project is a systemic problem, not a medical problem. It is a public health concern, but public health professionals have been ineffective at changing this nationally. And anybody who works on this knows that that's true. So as I will show you in these slides, this is a business intervention with a public health goal, and a clinical goal as its driving factor and force.
Great. Well, I remember one of the things that first impressed me when I learned about this project was precisely the fact that you were accomplishing a lot of this transformation within an emergency department setting. And I remember one of the first questions I asked you was, how do you do that in an ED setting, especially during COVID with all of the overcrowding and all of the staffing challenges that we had? It was just, I'm very excited to learn about how you approach this and how the background you had in doing improvement work in your ED blended in with your ability to succeed here. But I do wonder if you could talk a little bit about where did the passion and the interest come from for you as an emergency physician to kind of tackle this problem? How did you learn about this? How did you develop an interest in it?
Well, all of my projects have been centralized around the same idea, and that is that every person seeking our care is deserving of the same high quality care as every other person. And that's driven by my worldview and my faith. But specifically, every project I've worked on has been an access to care issue. So when I came to UK, again, 4-hour wait times, and I told at the time the medical director and the chair and other people, I said, if we have to go out in the waiting room to take care of people, we'll do it. And so this project is no different than all the other projects that I've worked on. And what I saw was in the early 2010s, a new cure that came out for this, the direct acting antiviral agents. Those of you outside of emergency medicine may not be aware of these drugs, but essentially a cure and a cure that's pangenotypic and basically almost 100% cure for anybody who takes them. And there's almost no side effects with them. Pregnant women can take it, babies can take it at this point. And I saw in Kentucky, we did 500 large volume paracentesis annually in our emergency department. And so I was seeing these 30 and 40-year-old people that came in with decompensated cirrhosis. And I've personally cared for numerous patients who have exsanguinated from varicose bleeds, for instance. Mm-hmm. And it was every single shift I had, every shift would do a large volume paracentesis because the volume of patients we had was overwhelming our hepatology clinic and any other outpatient capability. And I just thought to myself, why do these patients not have a cure? I mean, why are we seeing decompensated cirrhosis at this point for something that's so easy to diagnose and they just need a pill? And I thought this was going to be a very easy intervention. And, this is now a 7-year project. And we have built, according to some of the international experts, the most effective program in the world. But it took a lot of work. It seemed very easy, but what I've learned is that it's purely been an operational logistics, red tape kind of problem. And it's just taken perseverance to eliminate all those barriers.
Well, I'm really looking forward to this presentation. We'll go ahead and move into that. I would remind the audience that if you have any questions or comments, please include those in the comment section, and Daniel and I will have a chance to answer those at the end of the presentation. So Daniel, I'll get your slides up here and we'll get ready to go.
Sounds good. So I'll try to get through these slides in about 30 minutes, and then we'll leave some time for questions at the end. But I'm going to go ahead and answer one of Don's first questions, which is, what is a syndemic? And I'll explain that. So tackling hepatitis C with leadership and strategy, I've named this model the CURES model, which is a cascade utilizing routinized screening through treatment to eliminate syndemics. So a lot of places nationally have screening programs. A lot of places have treatment programs, but there is essentially no place in the country that is putting this all together under one team with a standardized team that has eliminated all waste and variation. And the Syndemics is dealing with multiple epidemics that are together. It's kind of it is a term that's used within the public health world. So in this particular case, it's hepatitis C and the opioid epidemics both working closely together, and that's why it's called a syndemic. But there are other syndemics such as HIV and syphilis, but it's just epidemics closely being associated with one another. So just financial disclosure, I do have salary and grant support from Gilead Focus. Gilead Focus is a nonprofit arm of Gilead Sciences. For those of you not familiar with it, it's a phenomenal program. They support screening infrastructure there, and it ends at first appointment. So they have nothing to do with anything on the right end of the spectrum with treatment. That's been all me. But they've supported me about 10% of my salary and my team. And before some of the guidance changes, they were responsible for testing and screening. So they're a great program. I'll talk about them quite a bit. I've been very impressed with my partnership with them. And also I'm an owner, and like they said, in my own physician group now. I've started and practice clinically within my own emergency medicine group now. So the executive summary of this is that I work and operate in Appalachia, and the syndemic of HCV, HIV, and opioids has disproportionately affected our region. But anybody practicing in the United States, this is affecting you, as if you've looked at injection drug use over the years and the changes in that prevalence. And what we know is that current models of care, specifically for hepatitis C, which is what I'm going to focus on today, have been inadequate to reach any goals of elimination. I'm going to be presenting to you a first of its kind standardized enterprise model of care utilizing specialty pharmacy through a collaborative care agreement in the emergency department and throughout the rest of the institution, aimed at increasing service rates while decreasing variation and waste to optimize all KPIs across the continuum of care. Or the cascade of care. And this is combined with other syndemic approaches such as opioid use disorder and HIV, et cetera. Just if you're an ER doctor, you've heard this terminology before. This is a process, not a location. So this process can be done anywhere within a healthcare system, just kind of like a observation unit or a fast track. This doesn't necessarily have to occur in this location, but the process can be done anywhere. And we hope that this is a replicable model that we're going to be taking through Kentucky and the rest of the country. We'll talk about that later. But we've gone from average diagnosis, time from diagnosis to treatment of 400 days down to 15 days, and our treatment rates have increased by 500%. And within our system alone, just within UK healthcare, we estimate about 35,000 HCV RNA positive patients who are treatment eligible. Most importantly, as I will discuss, there's going to be a multi-billion-dollar cost of inaction, and this is largely falling on Medicaid. So regardless of whether or not healthcare systems and payers choose to engage in this and spend money on trying to fix this, they will have some downstream, very predictable costs of inaction. And we believe that this is a possible model or that should be leading to state and national elimination. So for those of you on the call, this is not new information, but background here is just that the opioid problem has continued to worsen, particularly after COVID. And now that we're seeing a lot of fentanyl, the importance of fentanyl is that people are injecting more often to get the same kind of high. That, the people using drugs, they know about overdose, so they're injecting more frequently, more often. They're also injecting with meth and doing it with a lot of sex activities as well. So the actual needle exposures are significantly increasing, which makes a lot of people in this particular field believe that the HCV that's associated with this is only going to get worse. My region, which is shown here by these circular graphics here, is we're in central Kentucky, but a lot of our catchment area as a referral center is in Appalachia. Really interestingly, there's very little data on hepatitis C in actual rural areas. So a lot of the emergency department screening programs have been in urban areas such as Oakland or Birmingham, Alabama, or Johns Hopkins, Boston, Lexington. But we do serve about 50% of our patients are from an Appalachian county. But so this is there's still a lot that's yet to be known in the rural areas. But what a lot of people don't know is that 54 of the nation's top 200 counties at highest risk for infectious disease outbreak are in Kentucky, and this is largely secondary to the epidemic. So background on HCV, about 2.5 million to 5 million people are living with chronic HCV because of lack of screening and because of the way that this is reported, particularly in Kentucky, for instance. This is likely a huge estimate. We believe in Kentucky, based on some Medicaid claims analyses, that there's at least 100,000 people living with RNA positive HCV in Kentucky. The vast majority of them are undiagnosed. Most of them that have been diagnosed have not been treated, because a lot of physicians are stuck in the old era before direct acting antivirals, or they still think that there are still barriers to treatment, such as the need for advanced fibrosis, chronicity, needing to be treated by a primary or by a specialist. There's a lot of misconceptions out there that have gone away, but for a lot of reasons, either patients haven't been screened or they are known positive and haven't been treated. And this is a really interesting fact that the vast majority of people I've interacted with don't know, but pre-COVID, HCV caused more deaths from communicable diseases than all the other 60 reportable communicable diseases combined. Since COVID, this fact would still be true. It's just, COVID clearly was changed that statistic a little bit. And again, in Kentucky, only 10% of patients have been screened over this 10-year analysis, and only a 7% year-over-year incremental screening. So very few people are being screened, particularly in the highest risk populations. So this is where a group like Gilead Focus is very important to help build infrastructure in places where which is really everywhere where there's risk. Importantly, the National Academies of Sciences, World Health Organization said, hey, we've got a cure. This is easy to diagnose. We need to eradicate this disease by 2030. That was recommended before COVID, but they said, we think we can do it. And we are far behind that in the United States. And there's some evidence that most people are at advanced stages on diagnosis once they've been diagnosed. And as I'll show you with our screening program in the emergency department, that is not the case if you catch this early, such as with ER patients. So what we know, this is from the CDC. If you look at the top two, the light green and the blue, this is being driven by young patients between 20 and 40, and that is because of the opioid epidemic. So the history of this, when I first was training at University of Alabama, Birmingham, under Jim Galbraith, who was kind of a pioneer in this area, we were doing this in a targeted fashion. So the CDC said, hey, why don't you screen people based on targeted risk factors, such as if you're a baby boomer or if you've done injection drugs. So that was kind of how we started emergency department screening from a public health standpoint. And what we found, and this is, if you look at the paper on the right, what we found is that doing seroprevalence studies, we found that about 25% of patients were being missed if you were looking at targeted rates. So very quickly we knew that the standard of care and the best practice was to be doing non-targeted screening. Some people use the word universal screening, but nobody really has done universal screening because most of these programs have been done on people that are getting blood work drawn as part of their routine care. So still a lot of people being missed, but non-targeted screening is what we're doing. So in 2020, the CDC and the United States Preventive Task Forces caught up with existing work on this. And they said that just like with HIV in around 2005, 2006, that if you have a prevalence greater than 0.1%, that you should be screening for this. Their language was all patients over the age of 18 at least once, all pregnancies, and more frequently if there are risk factors. No one has defined the cadence of screening. We don't know how payers are going to respond to more frequent screening, but I will tell you that my opinion is that if you're in a community where there's high risk, so if there's injection drugs in your community, which is pretty much all communities, particularly in emergency departments, that annual screening is a good idea because there exists risk factors, and that cadence of screening has not been defined. But I'll tell you, we have not had any issues with payers that we know of. Also, anyone who wants it. So if somebody comes in and says, "Hey, I want this," then that should be offered to them as well. And the last point was just what I was talking about in terms of the cadence. But essentially, there's guidance now from the CDC and U.S. Preventive Task Forces to be doing this screening, and very few people are screening for this. So in Kentucky, and I can't speak to all states, but in Kentucky, one of the barriers to screening for HIV in particular was that the ordering doctor had to be the one to disclose results. And thankfully, we had some legislation that was passed that allowed a designee to follow up on it. So you'll have to look at your own particular state. And in our state, as long as there's language in the general consent to be screening, you really don't need any other consent. So we're not even asking opt-out screening anymore. In the same way that I would, if I was a primary care doctor and I was going to get an A1C or in the ER and get a CBC or a BMP, I'm not asking the patient for their approval of doing this. I'm just doing it because it's the standard of care. Regarding HIV, I'm not going to spend a lot of time on this, but just remember this is a syndemic. And really importantly, this model that I've built can be applicable to any disease state. So basically what we've built is a screening model with a standardized team to go through treatment with a prevalent disease. So this has future implications for the new terminology is MASH, which used to be NASH, non-alcoholic liver disease. This has implications for diabetes. This has implication for cancer screening. So this type of infrastructure can be used in the future of, I think, emergency medicine is I think the ship has sailed with trying to keep people out of the ER. And I kind of get frustrated with ER doctors and residents for continuing to harp on this. If you want to see critically ill patients, go do critical care fellowship. That we are where patients exist, and we should be doing everything in our power while patients are in front of us to take care of them. And this is a good example of that. But with HIV, there's still a lot of people that are unaware of their diagnosis, and most of the viral transmission is happening in patients that are having new infections. Basically, I was able to get this built upon the HCV existing infrastructure, and as stated above, we were able to eliminate policy-related things that kept us from getting this done. But so we are screening for HCV and HIV in our emergency department and in our primary care setting now. So this is as of August, last time I updated this slide. You can see the cascade of care. I want you to focus on two things. One is that the HCV seroprevalence in our ED has remained about 10%. This is consistent with what most literature has shown in different emergency departments. Of those aged 20 to 40, which I did not include on this particular slide, the seroprevalence is about 20%. So I have about the same seroprevalence of hypertension as I have somebody having HCV antibody positive patients in those aged 20 to 40. So it's a really prevalent disease. We have diagnosed actually as of today, closer to 6,000 RNA positive patients. This is as of August, this slide. The historic 70% or 80%, so 20 to 30% clearance on this disease is not what we're seeing in most of the literature. We're seeing closer to 50%. The younger you are, the more likely you are to be RNA positive. The older you are, the more likely you are to have cleared. That's, I think, for clear reasons that a lot of patients are dying either from overdose or from decompensated liver disease. So those who are surviving have cleared the virus. This is probably the most important part of this. So remember I said that historically a lot of the patients that had been diagnosed with this were advanced stages. So what we are finding is that the majority of these patients are young. They are almost universally Medicaid or Medicare insured, and they do not have advanced fibrosis based on non-invasive fibrosis assessment. So they basically do not have any evidence of liver disease. They just need a pill to cure them. We have diagnosed, we're about a 1% seroprevalence of HIV. The vast majority of these patients know their diagnosis, but we've had opportunities to link them to care. many new diagnoses associated with this as well. I'm not going to present the business case on this, but it's also a positive return on investment to be doing this type of screening. This is the second wave, as I was talking about. If you look at the graph on the right, the dotted red line are Black patients, and that's usually those in the baby boomer cohort. But this what's driving this, as I showed for that CDC slide, is this young white injection drug using population. And again, the vast majority of them don't have advanced fibrosis and are Medicaid insured. This is just some epidemiology information, but when I did this study, 93% of these patients were Medicaid or Medicare or uninsured. So again, the burden of inaction will fall on the state, will fall on taxpayers, regardless of our choice to intervene. This is looking at fibrosis. So we are finding that the vast majority of these patients do not have advanced fibrosis. We're doing elastography, we're the first place in the world to be doing elastography in the emergency department. I'll discuss that a little bit later, but we're not just throwing drug at patients. So a lot of the national elimination plans have had this Netflix or subscription model where they have a deal between the drug companies and the state, just basically giving unlimited access to drug to patients. But that completely loses sight of fibrosis, of hepatocellular carcinoma, of varices, of co-infections, of vaccinations. So we're treating the whole patient with our system as well. So this is important. From 2015 to 2020, treatment rates went down nationally. So in 2015, the National Academies of Sciences said in order to eliminate this disease, we needed to treat 260,000 patients annually, and in order to eradicate the disease. So we've dramatically fallen short of that. This is kind of leading to one of my points, is that access to drug significantly improved during this time period. Barriers to treatment, all those things I talked about have been falling very quickly in most states. And there have been these Netflix models, yet treatment rates have still gone down. So this has been one of my arguments, that this is not a medical access to care problem. It's not a medical problem. This is an infrastructure problem. And that is what what I am telling people, is that you must have a new and different model of care infrastructure to deliver these drugs and everything if we're ever going to eliminate this disease. So this is a paper published by Bill Thompson with the CDC. This is just demonstrating nationally what I've shown locally. This was a paper showing treatment rates in the United States. This is published in the CDC's MMWR. And what we found was that most patients aren't getting treatment, as we already knew, but those most likely not to get treatment are the young patients who are Medicaid insured. So exactly the predominant cohort of patients we are identifying are those also most likely not to get treated nationally. This is a graph showing the treatment failure. So one of the things that I was able to do within our own system, in order for them to fund this crazy model that I came up with, I had to show their own failures. So this is a graph showing the failure within UK healthcare. The gray line on the bottom is the patients treated within our system. The red line on the top is patients diagnosed with RNA positive. That inflection point was when we added a second ED of screening. So you can see that the diagnosis rate is far outpacing the cure, which obviously cannot continue. From a public health standpoint, the R naught is out the roof. So people are infecting far more patients than we are curing, and this cannot continue to happen from a public health standpoint. This is a screening failure slide within the ambulatory setting. So again, we recently expanded screening in this whole process into the ambulatory setting, but we've had over 2.2 million visits since we went live with Epic, which was several years ago. And of those, there are 275,000 unique adult patients. Only 16,000 of those had an antibody test with a seroprevalence of about 4.5%. So again, this was after the United States Preventive Task Forces, after the CDC recommendations. And I would guarantee most of you in your sites are going to have similar screening rates because people just aren't aligning with these. Love this quote. I know in this program, probably a quote that gets thrown around a lot, but this was all by design. This failure was all by design. So we needed to design a new system. So systems change over time. Again, a huge component of this was I could have gotten none of this off the ground without Gilead Focus. And anyone interested in this after the program, particularly those of you in Tennessee, I'm good friends with a lot of them now, and I can get you hooked up with them. But still to date, there's a lot of these services that are not reimbursed, and Gilead Focused is necessary to get some screening off the ground. You can see the systems change. The red circle was the physician executive MBA for me, which is what I did my master's thesis, my OAP on this project. And that helped me catapult this work, because I took my master's thesis to the chief executives and said, hey, look at this opportunity. And ultimately, a lot of things came from that. This is the title of my OAP. Chuck Noon was my mentor on this. And again, just went to my chief physician executive, handed this to him, told him to read it. And a lot of things happened downstream from that. We built new business plans and so I had all kinds of presentations to have this vetted, because it almost seemed too good to be true. But was able to justify several $1 million additional incremental investment from UK Healthcare to build a big team out from this. This was a slide that I presented to our chief executive at the time, our CEO. There's all kinds of logic that went behind this, but basically what I showed was there was a several $100 million opportunity for UK Healthcare, that tens of thousands of patients could be treated. I'll show you a little bit later, but billions of dollars potentially saved from Medicaid. So there was a win-win-win-win for everybody. Positive value added for every stakeholder in this. And also the cool thing about this was that we had to have very little success in order to justify the resources we were asking for. So this is what we were asking people to do. We were asking patients to show up, get their screening, to follow up, and essentially just all kinds of unnecessary steps. And this is what most places are doing this. And this is in a very, very difficult patient population. And what we found is that we really had to take the treatment to the patients, similar to a physician intake system in the ER. If you ask patients to show up and then go to a room, then see a resident, then see an attending, and then get their workup started, right? It's completely inefficient. It's the same idea here. We took the interventions that were necessary to the patient. So after I had this business plan justified, we had a Kaizen event. This is still in the middle of COVID. We sat down, we mapped out the processes, we built a new process. We did all the things that PEMBA teaches, all the things that Chuck teaches, and we just applied that to this problem. So this was part of the Visio diagram of the pre-states. So paper on the right showed the cascade of care, showing huge attrition. The biggest attrition in most of this is diagnosis to follow-up appointment. So what we knew very quickly was that there had to be some type of intervention, essentially at the point of care, that was going to be effective, if anything was ever going to be effective. But this was the pre-state. The future state, this is a slide I made from 2018 on the right, which shows how long I've been thinking about this. On the left was the new workflow that we designed. But we knew that pretty much all of these things that we needed to do on the right could be done in the emergency department. So I knew long ago that it was possible to do this, and it just took a long time to do. So this is a simplified workflow. The actual workflow of this is taking the AASLD and IDSA guidelines and which, if you're familiar with this disease state, and just applying them in the emergency department. It's not rocket science. Basically, the vast majority of these patients fall into this simplified, as the insurance payers call it, simplified, the patients that don't have advanced fibrosis and literally just need the pill. They don't even need follow-up. And we applied all of these things in the emergency department. So patients that are previously treated, co-infected with hepatitis B or HIV, or they have decompensated cirrhosis, we are still referring those, but it's a more appropriate referral. Just like everything else in emergency medicine, this is no different. We're treating the patients who are low risk, the really complicated patients we're referring. So this is an appropriate triage, just like every other disease state in the emergency department. And this is our results. This is as of a few days ago. So the gray boxes are a statistical process control showing the variation of diagnosis days through treatment. Now, I want to be clear here that this falsely conflates actually what was happening, because if you look at, for instance, that black line on the far left of the screen that shows, several hundred patients being treated, that was after 5 years of efforts, 40,000 phone calls. So we were able to get those treated because we tried to find them for years and years and years and years and years. And so that's part of why the variation was so massive, because a lot of this over time was our efforts over time to find. We've got this list of 6,000 patients and we had treated less than 1,000, and we just kept calling them over and over and over again, trying to find them. Or a lot of them had died. Almost 1,000 of them had died with an average age in the 40s. So huge opportunities that were missed on those patients. But either way, if you look at the diagnosis date through treatment, what we found was massive variation in low treatment rate. And if you look all the way to the right where the red arrow is, that is when our UK specialty pharmacy treatment model went live. And as you can see, our variation has dropped down to essentially zero. So we have a standardized protocol. We have very specifics of what we're doing in this collaborative care agreement with the pharmacists. The pharmacists are carrying out all the work on behalf of the physicians, so functionally dramatically increasing the service rate of those physicians. They're doing it at the point of care, but also in follow-up. We have a clinic through this for patients to follow up with. So patients that we previously had diagnosed now can get into the same treatment team, all the same algorithm. Again, a process, not a location. And our treatment rates have gone up 500%. I would actually say that number is actually comparing it to zero. So historically, we would make a diagnosis and we wouldn't be able to get them into our GI or infectious disease clinic for months. And now we're getting those patients treated within 15 days. So it's really comparing a 0% treatment rate. Now we're treating 63% of patients eligible. We're interacting with 100% of them before they leave. And we're treating 63% of them. Before we were treating 10% after 5 years of effort. And so it was difficult to show graphically, but the improvement is astronomical. And this has gotten the attention of everybody across the country. I presented this at the Gilead National Conference. CDC viral hepatologists I've presented this to. We were recently told by the director of Gilead Medical Affairs, who his team is responsible for 10 million treatments across the world. He told us we had the most effective program he's seen in the whole world, other than an Iceland prison system. So, we're still early on. We're just a few months into this treatment side of things, and the legal hoops I had to jump through were unbelievable. We can discuss that later, but again, just being persistent, getting this off the ground, convincing everybody it was the right thing to do, doing it. And since we went live, so we had already made about a $15 million profit on this. And that was before this, but in the last few months, we've had about $4 million of revenue, about 50% operating margin within that. So and the incremental investment we asked from UK was about $1 million. So we've already broken even, and made additional money. And that money is, largely from 340B margin, but it's allowing money to be poured back into the organization, back into the institution, and allowing this to grow. So of the eligible patients, 312 have been eligible for simplified treatment. Of those ineligible, some had already been on direct-acting antivirals, so very few. So it's an interesting number. So most of these had not been treated before. A few of them had decompensated cirrhosis or portal hypertension, had some co-infections. And because we're actually intervening at the antibody step, we've actually found 4 additional HBV patients that previously would not have been identified if we would have just intervened at the RNA step. Again, we're the first place to be doing FibroScans in the emergency department, which we believe is the standard of care for fibrosis assessment. Interestingly, we are seeing a discordance between the FIB4 and the FibroScan. So the FIB4 is a score, if you know what this is, it's a non-invasive score for fibrosis that uses age as part of the scoring system. We would not do that for any other. We would not try to decrease risk stratification for chest pain in the ED based on age, for instance. And that's what we're doing here. So it's a bad score. It's the standard score, but it's a bad score for a cohort of patients that's largely young. So we're finding significant discordance on people where the FIB4 said they actually were not at risk for having fibrosis or cirrhosis, and we found a significant number who do. And that has significant downstream implications for how we treat them, for whether or not they get hepatocellular carcinoma surveillance, variceal surveillance, et cetera. So that's huge, and that's new information in the literature, hasn't been published. So we just hit our 200th patient a few days ago, and that number is continuing to rise. I think we're running out of time, but I'll try to fly through the next few slides. So importantly, this is the most important of all the information. If you're going to take anything away from this, is that this has a very predictable cost of inaction. Lots of literature published on this, but most recently, we believe it costs about $210,000 to not treat somebody with hepatitis C. And that's because of all the associated problems associated with it, the downstream morbidity, extrahepatic manifestations of the disease, et cetera. But it costs about $20,000 to treat. And again, the vast majority of these patients are Medicaid. So it's about $190,000 you save per patient you cure. Other literature has shown $25,000 per patient per year that you save. So no matter what, it's massive amounts of savings. The biggest stakeholder here is very clearly Medicaid. I believe very soon we're probably going to have a carved out budget just for this program within our state. And we hope to have bigger conversations with the White House, with Francis Collins and other people who are working on this, because they must understand the cost of inaction here is great. There is a $15 billion budget line item with the Biden administration right now specifically for hepatitis C. But again, there's been no appropriate infrastructure to pour that into. And we believe we're one of the first and the only that has demonstrated success. So this is a slide that I'm going to give Chuck Noon the credit here. I think he's on here. Expanding the pie, as he called it. Basically, the models that have previously existed on this completely eliminated the healthcare system as part of the discussion. The Netflix model or the subscription models that the White House is currently pushing, that Louisiana and other places have done, they have failed because they forgot about the healthcare system. These patients exist within the healthcare system, and the healthcare system must be incentivized to do these projects. So there's two places where these patients are in the United States. They're in the Department of Corrections. They're in emergency departments. Emergency departments are within healthcare systems. So healthcare systems must have an incentive to do this, and we have built a model that incentivizes the healthcare system. It incentivizes everybody else too, but that's why we think our model is different, because we identified the key stakeholder in this and brought value to them. So we now have a grant with the Department of Corrections. We're screening there. We're seeing a 65% seroprevalence after several months of screening of all patients discharged from our local jails. That number is way higher than anything previously published. And again, if we don't get into prison systems and treat patients, regardless of your political views of what we should be doing in prison, again, the cost is going to fall on taxpayers. We are expanding to other emergency departments. Long story, but we have plans to expand to different areas in the state, and we're working on that right now. So I love this quote: "If you do what you've always done, you'll always get what you've always got." So we realized that something different had to be done, and we did it. It took a long time, but starting to pay dividends. And that's it.
This podcast is sponsored by the Physician Executive MBA program at the University of Tennessee Knoxville's Haslam College of Business. In less than one calendar year, this program will equip you with valuable business acumen and leadership development not found in traditional medical school curriculum. Are you ready to join the longest-running physician-only MBA program in the country and a network of nearly 1,000 PEMBA graduates? Visit tiny.utk.edu/POD podcast for information about this exciting opportunity. And now we'll return to the episode. Great. Well, thank you very much, Daniel. That was great. We do have a few questions in the chat here. Initially, there was a question from Dr. Leiter about how these interventions work in primary care offices. You did touch on that a little bit, but how many primary care offices have you expanded into? And have you seen lower positivity rates than compared to when you screen in the emergency department, but just equally rapid initiation of treatment? Or how does it look, similar versus different?
So it's still too early to tell if the treatment intervention is going to be effective, but it almost certainly is going to. A lot of this is education and just making people aware of their lack of screening. So case identification is going to go way up. We're screening now in family care, family practice, and a few other locations in UK healthcare. That's been off the ground only a few months. So that's really early. But the published literature on this is that the primary care location is going to be about half of the seroprevalence of the ED. So it's still going to be significant. And we do know that the same problems with referrals and treatment variation and the artificial variation within the system, as Eugene Litvak calls it, is still massive. So having a single team to intervene with protocols is still needed. And also the location where my business is, we are going live April 1st with a system-wide screening program. So it's the first place outside of UK that this will be being done. I'm still working with UK and this other hospital on how to, because it's kind of messy. Is this my intellectual property or the university's intellectual property? So we're trying to figure out a way to work together on this and get this off the ground at another community hospital. But we have plans to do it in a lot of other locations. So to be determined in the other locations, but it almost certainly will work.
So one of the things, and Dr. Leiter had asked another question about cost of care, which I think you kind of answered as you went through this. But what about the question here that he asked about incorporating this kind of approach into medical education, both undergraduate and graduate medical education? Yeah,
I've given a few lectures to undergrads, to medical students and residents, but we are far away from that being any type of incorporated data or incorporated skill set. It has not been emphasized. And I think because of that, those of you who've worked in healthcare systems, physicians largely are not the ones making decisions. They're not the CFOs. The CNOs typically have far more power than CMOs in healthcare systems. I think we're laying in our own grave that we dug to some extent. I mean, we excluded this administrative and operational training long ago in our training programs. And I think if we ever in the future want to be back in control of healthcare systems as physicians, that this has to be universally taught to students and residents.
One of the things that I have a question about, I guess, is as you look at how to really cause this national eradication and achieve the goals that have been set by 2030, it certainly seems pretty daunting, the fact that we're already in 2024 and we've had such little movement on this initiative over the past 10 years. And you mentioned that your state is starting to potentially set aside some specific resources for hepatitis C eradication. Are there, and you mentioned some work that's going on in the Biden administration, but fundamentally such a large percentage of these patients are Medicaid, which are state types of funding issues. And we've seen such a variation across states with Medicaid expansion. And now in the state of Michigan, for example, they're having to recertify, which was postponed during the COVID pandemic. But we're starting to see a reduction in the Medicaid rolls since June of last year when they started having to reapply for Medicaid. What are your thoughts about how this can become a truly national treatment approach?
Yeah, it's still a daunting task ahead of me. Again, a lot of this has been, I am getting paid for this work now, but it's been a lot of work. And because a lot of the services aren't reimbursed, because this hasn't fallen into a nice package or box within a healthcare system or a department, the future is yet to be seen. So what we're doing right now, what my thoughts are right now, so I've engaged the board of directors with the American College of Emergency Physicians. I've engaged the viral hepatology department at CDC. We missed this year's budget in the state of Kentucky, but I'm working closely with Gilead, Gilead Focus, Gilead Medical Affairs, and something similar to what I would like has been built in Florida with HIV. So they built what they call a public-private partnership. And I personally don't mind working with industry on this. In fact, I 100% could not have done any of this without them. And Gilead is interested in any location where we can work on this. They would be interested in building infrastructure. I mean, for obvious return on investment for them, it makes sense as well from a business standpoint. But what we need to do is we need to work together, a public-private partnership with the state, and have carved out money from the state to build a team that is ran by effective individuals, where there's appropriate data and a cohort or a database of patients and these types of processes to be incentivized and reimbursed in community hospitals and settings. Because this must be done on a widespread scale in every location, not just academic centers, for this to ever be effective. Also, from a Medicaid standpoint, we've already tried getting some coverage changes for patients that are in jail and in prison. That has so far been not successful. But we have to get in front of the lawmakers, which I've been doing with Gilead and with ACEP. We've already worked on some policy things, some advocacy, but we really got to be able to make the argument to them, and which we haven't done yet. I mean, we're brand new. We're still new. This data is still only a few months old in terms of the success that we're having. And again, we're the first people ever to show the success. So, I mean, it has made sense in the past not to invest in this. And in fact, I think the money the Biden administration is about to release on this is going to be wasted without effective models of care, because we're just going to be worse than we were to begin with.
So one of the things,
lots of work that needs to be done, and way more than I can personally do.
I was out in Washington last week doing some advocacy for federally qualified health centers, and the looming deadlines of March 1st and March 8th that was involved in a lot of our conversations with legislators, just in terms of government funding and all of the politicking that's going on around that right now. So it'll be interesting to see how these next 2 or 3 weeks play out and what kinds of funding opportunities actually exist for programs like this and for federally qualified health centers, because our funding bills haven't been approved yet. So there's a lot of uncertainty right now in a lot of areas of healthcare that I'm involved in.
Well, I'll tell you, we have 2 sites, 2 FQHCs that we have targeted as our next. So, stay tuned, because we're going to be intervening there. I wanted to address, Chuck asked, assuming there was some degree of early resistance from ED clinicians, are they fully on board and proud of this program at this point? Yes. Just like the physician intake system, when they see the success of this, that they're on the back end, especially when it brings money, notoriety, and things like that to the department. Yeah, they're all on board. In fact, it's for them, it's a recruiting tool, because a lot of students nowadays are very interested in public health work, and we built one of the best. I don't think Chuck knows this, but I had to leave the Department of Emergency Medicine to work with pharmacy to get this accomplished. But the ED clinicians are very proud of this at this point. And again, using this as an infrastructure. Another really interesting thing about this I forgot to mention, I know we're running out of time, but it was this infrastructure that allowed us to handle COVID so well. So because I already had the screening infrastructure and the segmented flow from this already, all I had to do was add COVID in and a few other risk factors that were very easy to do and flip a switch. And it was, our first 2 years of COVID, we only had one healthcare worker get COVID, and nobody picked up on that. I don't know why from a media standpoint, but I think it was because our flow, our segmental flow, and our EMR modifications were already so robust that we were able to turn it on in literally like one day. So that was really cool. So, the ability to deal with future epidemics, future pandemics, the ability to turn this on for breast cancer or, diabetes or liver fibrosis. There's a lot of implications here. And I think a lot of interesting applications where the ED can be utilized as a new source of revenue and value for healthcare systems.
That's great. Well, this is an exciting project. And I'd be interested to know, too, in line with Chuck's question, what was the turnaround, or what was the length of time that it took for the physicians to realize the value to them of buying into this approach? You've been working on this for 10 or 15 years, Daniel. How long did it take to kind of turn that negative attitude or that resistance to change into the type of support you see now?
Years. Same thing with any project I've worked on, significant resistance, people not wanting to change. It took years. It takes data. It's years. And, I've had a lot of pushback on a lot of different projects, sometimes very aggressive. But usually people who care about patients, which is the most, not all, but usually they come around and are thankful for what we've done. But, if you're in the old school mindset that the emergency department is only for emergency departments, something like this will never make sense to you. This is also redefining what an emergency is. An emergency is something that is life or limb threatening without intervention. And this is, does the patient have an emergency complication in its historic sense of hepatitis C in the emergency room? Absolutely not. But when their mortality is higher than that of a STEMI or a stroke, and when I don't do something about it in my setting, that is an emergency. So, it's been really easy to convince people of that, but it's certainly not the standard national thinking, but I 100% believe that emergency departments should be thinking this way.
Yeah, no, that's a great point. Well, thank you very much for appearing on the live stream today. This was a great show. And I really appreciate the time that you took to present this and to prepare it.
Thanks for having me.
So that concludes another episode of our PEMBA live stream for today. Thank you all very much for attending. Don't forget that you can have access to CME for this 1-hour session by going to tiny.utk.edu/PEMBA on demand. I hope you all have a great afternoon. That wraps up our show for today. Thank you very much for joining and listening to the podcast. If you have any comments or questions regarding this episode, please feel free to add them in the comment section on our website, tiny.utk.edu/POD podcast. We love hearing from you and are happy to answer any questions you may have. I will add a link to the website below. Please also don't forget to subscribe to the podcast by clicking the subscribe button. Add PEMBA On Demand to your podcast library today. I would also appreciate it if you could leave a review of the podcast on your podcast player. Share the podcast with your friends and colleagues also. Please take good care of yourselves, and as always, good luck with your future.